All right, let's get started. Good evening, everyone, and thank you for joining us for the Center of GI Cancers, the CME webinar series at Yale for the gastroesophageal cancer segment. I'm Raghav Sundar. I'm a GI medical oncologist and leader of the gastroesophageal cancer program. These are my disclosures. Um, so for the past few months, the Center for GI Cancers have had a webinar series. This is part 3 of this webinar series. In February, we had a GI Oncology Year in Review. And in March, for Colorectal Cancer Awareness Month, we had the colorectal series. And this month, we're going to do gastroesophageal cancers as a part of the Gastroesophageal Cancer Awareness Month. And I'm pleased to be joined by 3 fantastic speakers who will be talking to us about different aspects of the multimodal discipline of um, gastroesophageal cancers. So I have Professor Dan Boffa, who's a professor of surgery from thoracic oncology, who'll be talking to us about surgical updates. I have Dr. Kevin Du, who's an associate professor from radiation oncology, who will be updating us on the latest in radiation oncology for gastroesophageal cancers. And I also have Dr. Joanna Gibson, who's an associate professor of pathology, who will be talking to us in the latest in the biomarkers of gastroesophageal cancers. And to get things started off, we'll start with Dr. Gibson sharing with us a little bit about what's up and new in the pathology space for gastroesophageal cancers. Dr. Gibson, please.
Thank you. So as you can see, I went with a green background because it's spring and I was inspired. So it's not a diss at Yale. The Yale blue is wonderful, but I thought this was appropriate. So I have no disclosures. So just a broad review on the role of pathology in GJ adenocarcinomas. Obviously, pathology does the tissue confirmation of the diagnosis by looking at biopsies. We help with staging once a resection has occurred by reviewing the extent of the tumor and lymph nodes. We also assess metastases in a lot of different ways. And the main thing that we sort of also contribute to that has impact on how patients are treated is biomarker assessment. And in particular, I'm going to talk about the IHC biomarkers. So at Yale, we perform IHC biomarkers at reflex, at diagnosis through a reflex pathway. So reflex meaning that we do it whenever we have a diagnosis of a gastroesophageal adenocarcinoma. And whether that's primary at the site or metastatic, if that's what the diagnosis is, we will perform all 4 of these biomarkers at whatever time of the diagnosis. And one of the reasons why is because the percent of patients that present with stage 3 or 4 disease at the time of diagnosis is pretty high, gets into 70% or so for GEJ cancers. And it is helpful to have these biomarkers up front so patients can be triaged to the right treatment option. And while we perform IHC, we do use other techniques if necessary for assessment of confirmation or other biomarkers as well. And those are through a slightly different pathway. So I'm just going to go through each of these. The initial ones I'll just kind of walk through in an abridged way. So mismatch repair deficiency is the biomarker that I kind of like to say has double duty because it is used for a couple of different clinical contexts. So the biological basis for targeted therapy is immunotherapy targeting PD-1, PD-L1 pathway. And that's thought to occur because tumors with mismatch repair deficiency or MSI status have high tumor antigen and can activate the immune system. And so by using PD-L1 inhibition, we can sort of target tumor cells for immune-mediated destruction. And mismatch repair deficiency is predominantly tested using IHC. But we do have other techniques that can also detect it. But MMR IHC is a widely available technique that most laboratories have, and we're able to, and it's fairly easy and reproducible. So it's and it's fast. So we're able to do that. And that's one of the reasons why we start with that one. And then, how often, I'm just going to move one of the panels up to my other screen here. Excuse me for just one moment. How often is MMRD found in esophageal and gastric cancers? It's not very common. In one study from 2016, they found 7%. I recently reviewed a Yale cohort from 2018 to 2024, and we found about 11% in stomach cancer and a lot less in esophageal GEJ cancers. But it is an important biomarker that we need to identify because it does have this targeted therapy option. Another biomarker is HER2, and that's the old reliable biomarker. And the basis for targeted therapy is that some tumor cells will have overexpression of HER2 on their surface, and this can be targeted using antibodies or antibody drug conjugates. And again, we use a method of IHC. That's the main method of finding this biomarker on tumor cells. And in terms of how often we see it, probably seen in about 50 to 60% of GJ cancers. Kind of depends on which study you read, what cohort. It's been, this has been a biomarker that has been in practice for a number of years, and you can see that the use of this biomarker expression testing has increased from, 10, 15 years ago to more recently. And so we have a IHC component, and we will perform FISH testing if the IHC shows a 2+ pattern. And the exciting thing about HER2 is that even though it's been around for a long time and we've been able to target it using monoclonal antibodies, now there is newer data coming out that the antibody conjugates can be also used in even patients that have HER2 low 1+ or 2+ findings. So it is something that is going to be able to be expanded to other patients. PD-L1, I wish I could stop talking about PD-L1. This is the problem child for the IHC biomarkers. The biological basis for targeted therapy is the same, is very similar to MMR, where blockade of the PD-L1, PD-1 pathway can activate the immune system to eliminate tumor cells. We use the PD-L1 22C3 antibody, which is the FDA-approved method. And we perform what's called the CPS, or combined positive score. So that's the total number of PD-L1 staining cells in a tumor section that includes tumor cells, mononuclear inflammatory cells, over the total number of tumor cells times 100. And the problem is that the FDA-approved assay is the positivity cutoff is determined to be CPS greater than 1. But in trials, in certain trials, CPS greater than 5 was actually much more reliable and effective. And so it's difficult. And the CPS score of 1 is quite subtle. And there have been umpteen number of studies showing that pathologists are really not very good at being reproducible across pathologists. And one of the more recent papers on that is from our group, David Rim and Suchan Zhang, who are our pathologists here who've looked at that. It is more reliable at the higher cutoffs. So, CPS of 5 or more is probably more reliable as a result. And that could explain this variability, could explain some of the lack of efficacy for trials in this setting. So Claudin 18 is the new kid on the block, and I'm going to talk about this in a little bit more detail. So basically, Claudin 18 is a protein that's a transmembrane protein that forms the tight junction between cells. And normally, in the normal tissues, it's expressed. and you can see that it's in the tight junctions between the epithelial cells. But once cancer cell goes through carcinogenesis, becomes a cancer cell, the Claudin 18 can be retained on the surface of those cells, and it is also exposed because the tumor cells no longer stick to each other in the same way as native epithelial cells. And in looking at more detail at the protein, there's a loop with a couple of binding sites where antibodies can be used to target that particular protein. And in terms of what do we know about expression of Claudin 18.2 in esophagus or GJ cancers? And in one study, based on a positivity of greater than 75% 2+ or 3+ expression, we find positivity in about 38% of cancers. And you can kind of see that this high positivity here. This was the cutoff that was used for the study to look at zilbituximab, which is the main antibody that's targeting this pathway. But there are other novel antibodies that and antibody drug conjugates that could potentially be useful to target lower level expression of this particular biomarker. So if you include those, then you're adding a lot more patients to the possibility of getting targeted treatment. And I have a summary here of all the phase 2 and 3 clinical trials from one of the recent reviews for anybody who's interested in more detail. And so what do we do at Yale for Claudin 18.2? So we, again, use the FDA-approved assay, which is the 43-14A antibody. And when we report the results of our Claudin 18 staining, we report it in categories. So greater than 75% positivity, 50 to 75, 20 to 49, 1 to 19, and 0%. And that's because we want to be ready for those newer antibody drug conjugates and bispecific antibodies to see if these patients would benefit from those in the future. And again, you can kind of see what the spectrum of staining is. It's a relatively easy antibody to read. And then we always look for our normal controls in the background mucosa. Okay, so that's basically the end of my talk. I've described all 4 of these biomarkers and what they're targeting and how we assess them. And this is already out of date because we do have a emerging predictive biomarker, FGFR2b, that's coming up. And we are getting ready to have that IHC testing method brought on board for us. So this is just stay tuned about this in the future. And so here I have a summary table for anyone who's interested. So again, we have our 4 IHC biomarkers that we are performing as a reflex workflow so that we're providing this information at diagnosis and for the various uses clinically, and just again, just a summary chart of all the information I talked about today. And I'll stop there, and I'm happy to take any questions. And I apologize if I went a little too long. Let's see.
Thanks, Dr. Gibson. That was a great talk. May I encourage the viewers, listeners to put in any questions that you have into the chat or into the Q&A box, and we'll try and do them either now or at the end of the session when after all 4 of us speak, because I think it'll be quite helpful to have a multidisciplinary discussion at the end of all the chats. If there are no emerging questions, maybe we'll move on to Dr. Boffa, who's going to give us an update from the surgical perspective.
Hi there. Thank you very much. Dan Boffa. I'm one of the thoracic surgeons here at Yale. And I'm just going to talk briefly about a couple of aspects of the surgical management of esophageal cancer. So I have a couple of disclosures. This is what people think about when we mention an esophagectomy for esophageal cancer, that it's an extremely dangerous thing to deal with an extremely dangerous problem. And hopefully I can convince you at some level that it's become infinitely safer and the recovery is much different now with minimally invasive approaches. But I do think it's an important question. And do we need to do an esophagectomy in everyone? And I think that some of the most exciting trial data that's been coming through is looking at things that maybe we can be more selective in how we apply some of the traditional treatments as well as some of the newer treatments. So this, I'm going to focus on the SANO trial, which is a phase 3 trial that looked at selecting people to not go on to surgery after receiving the cross regimen of induction chemoradiation. Before that, though, you have to know that the person has experienced a complete clinical response. And so there was a trial before the trial, which is the pre-SANO trial, which was looking at could you tell if people had been cleared of their disease after receiving cross, because if you couldn't do that, then there's no point in the SANO trial, which is taking people who appear to have been cleared of their disease and selectively watching them to see if the cancer came back and deferring esophagectomy to only those people where the cancer came back. And so this was the trial to determine could you detect people that were free of residual disease. This was done in the Netherlands. Again, it was after the cross regimen. The 4 to 6 weeks after the completion of the chemoradiation, they underwent an endoscopy. And if there was viable cancer, they did a PET scan and an esophagectomy right away. If they didn't see any viable cancer, they did a second endoscopy, an ultrasound, a PET scan, and then everybody got an esophagectomy after the second evaluation. So there were about 220 patients. This was done a few years ago. They were mostly adenocarcinomas, and they wanted to see that of the people who had cancer still in them, what was the proportion of them that had a negative clinical assessment? And they called those false negatives. And so they started by just doing biopsies the way they routinely do biopsies. And they had a false negative rate of about 30%. So then they started doing a bite on bite, which just basically means that they took a bite and then went back to the same area and bit in the same area again, which gets a little bit deeper. Using this, they found the false negative rate, again, meaning negative results in people who still had at least 10% of their residual cancer. So it improved from 30% to 17%. And when they added FNA of nodes that were bigger than 5 millimeters, it went down to 10%. So 10% of the patients who had residual cancer, which they defined as greater than 10% residual cancer, had a false negative. And so this is a table by group, and the TRG at the top here, this is their different categories of residual disease. And so if you were a TGR1, you had a complete pathologic response, or you had 1 to 10% viable cancer, or greater than 10%, but less than 50, or greater than 50%. These are the categories that they code their viable cancer. And this is what the study was designed to look at, just these patients who had more than 10% viable cancer, and they found that there was a 10% false negative rate. But they didn't really look at the people with 1 to 10% residual cancer. And I would argue that patients probably care about that. That if you're really looking to see who's been rendered disease-free, you'd want to know any living disease. But what's funny about this is the way this was set up was to say, how well does the test perform? So given residual cancer, is the test coming up with a positive or negative result? Well, patients don't think that way. They don't care about scenarios and how the test performs. They want to know about test results and what does it mean. So if a test says no cancer, what is the chance that you actually have cancer? That's the false negative rate that really matters most to patients, and that points to negative and positive predictive value. And so when you look at all the people who had a negative test result, and granted that this was published saying there's a 10% false negative rate to this pre-Sano trial, but if you actually looked at everybody who had a negative test result, there were 29 negative test results. The patient still had cancer 55% of the time. And so that's just an important number to keep in the back of your head, that a negative Sano level evaluation, there's viable cancer half the time. So now to talk about the Sano trial. So this is a really nice trial done again in the Netherlands. 12 high volume centers, and it's a recent trial, similar to pre-Sano, mostly adeno and about 25% squamous. And again, it's the cross regimen. And they use something called a stepped wedge clustered randomization, which basically means the patients aren't randomized. The 12 hospitals, they only do one or the other, and what they do evolves over time. So everybody that goes to each hospital gets the same form of treatment, either cross then surgery or cross versus active surveillance. And every 3 months, hospitals switch from being a surgery performing center to one that does surveillance. So anybody who signs up for this trial, they know what they're getting because of the hospital that they go to. And then eventually all the hospitals were doing active surveillance. So with the start of the trial, every hospital, all 12 hospitals were doing surgery, cross then surgery, and then every 3 months, 2 hospitals were randomly assigned to take all their patients subsequent to that and do active surveillance. And so eventually more and more of the hospitals became active surveillance until all of them were active surveillance. And so it was designed as a 2-year overall survival from the time that they determine a complete clinical response. And it's non-inferiority, which means that they picked a margin. They said 15%. So if the difference in 2-year survival between surgery as following cross or active surveillance, if they were within 15 percentage points of each other, it was not inferior. And it's the upper boundary of the confidence interval, but I won't, that's not critical. So they screened about 1,100 patients, and interestingly, about 25% of all the people they screened did not want to participate this. And I think that's just important to sort of understand the appetite. And again, this is not randomized. They would know what they're getting up front, but they were not interested in participating in this. So there were about 760 that underwent that first evaluation, which was an upper endoscopy and an ultrasound. At that first evaluation, 36% were found to have cancer in the esophagus. So people got their chemotherapy and radiation. They had a 6-week, at the 6 weeks after the chemotherapy and radiation, they got an upper endoscopy. Just over a third of them, they still had viable cancer in the esophagus. And those that did not went on to the 12-week clinical evaluation, which is a little bit more involved, which was upper endoscopy, ultrasound, and a PET scan. And of the people that underwent that second clinical evaluation, another third were found to have viable cancer, but 40 of them actually, sorry, 40 of them actually had systemic metastases that they were found between their screening and this 12-week clinical evaluation. But they deemed 35% had a complete clinical response um, from this group. And from this, 111 underwent standard surgery, 198 underwent active surveillance. The numbers don't completely match up because they actually brought in some of the pre-Sano patients. And so this was the clinical response assessment. So 6 weeks after induction therapy, this was the 4 bite-on-bite biopsies. And if they didn't see any cancer, they went ongoing observation. And then at 12 weeks, they added a PET scan and the EUS. And if there were no tumor cells at the 12 weeks, they were deemed a complete clinical responder. And if you were getting active surveillance, then in year 1, you got the biopsy, the bite-on-bite biopsies, the EUS, and the PET scan every 3 months. Year 2, it was every 4 months. Year 3, every 6 months. And then after the 3rd year, it was annually. And when you look at overall survival, this was their endpoint. 74% of the active surveillance patients were alive at 2 years, and 71% of the standard surgery patients were alive. And so this is encouraging that there are people who can be actively surveyed. But I think the real interesting is how, what happened in to these different patients as they went along. And so if you divide all the patients up into and put them into the pie chart, you can get rid of the people who were excluded for sort of technical reasons. 55% of patients had, before they could get randomized or before they were made it to the point of being assigned to one of the 2 groups, they had viable cancer. About a third at each checkpoint, and then 5% had METs, systemic METs during this evaluation. And then if you look at the groups that underwent either the active surveillance or the standard surgery, it's a much smaller subset. And if we really focus on the active surveillance group, which is about a quarter of the patients that started all of this, and break them down, you can see that about 4% of them developed METs, systemic metastases, while they were undergoing active surveillance. Local only failure means they found the cancer in the esophagus, but nowhere else. That happened 12% of the time. 10% of them went on to surgery, while 2% did not. And then 8% of patients, there was no cancer in the 2 years of observation. They had no cancer, no return of cancer. And if we just look at the people who underwent active surveillance and just look at that subset, so 42% of patients underwent surgery eventually, after a median about 6 months. About 17% of the people that underwent active surveillance developed metastases, and 7% developed local only failure. Cancer came back in the esophagus, but they opted not to have surgery. So I think this is kind of an interesting perspective of things. So the first thing is, if these people waited 6 months, was there any downside to waiting? Because why not just do this for everybody if there's no downside to waiting, even if it's a very small percentage of patients that can avoid surgery, why not? And so the concern is that if you wait longer, people can develop metastases that they otherwise would not have. And so there was a difference that was not statistically significant, but a trend for a difference at 30 months, difference in the rate of distant metastases, 43% for the surveillance group and 34% for the standard surgery. This was not statistically significant, but it is it's approaching significance in my mind. And if you look at the disease-free survival, there is no difference in the period that was observed. But if you look, they are starting to separate after 2 years. You are starting to see a bit more of a disease-free survival trend in the people that had surgery. And so in sort of putting this together, 45% of people, if you do the Sano protocol, give cross, and then do these serial endoscopies 6 weeks and 12 weeks, you're going to find a complete clinical response in about 45% of people, but 2/3 of them actually still have cancer. And about 16% of people seem to be disease-free after cross only. So if you just give people chemoradiation, predominantly adenocarcinoma, about 16% of people are alive and disease-free at 2 years. So it's not a huge number, but it is a number, a reasonable number. And so again, because of people with persistent cancer, people that develop metastases, people who have recurrent cancer who were once cleared, that's sort of the impact. So you're really deferring treatment for the possibility that people have been cured with their non-surgical approach. And this is not terribly different from what we saw in the German trial with chemoradiation alone. The French trial was a little bit better in terms of survival, but 16% cure rate is not is a 16 to 20%, I think, is a reasonable expectation for non-surgically managed, particularly adenocarcinoma. But there were people that surgery is unlikely to help, people that develop metastases, and there were some people that were cured. And when you add all of those up, there is probably a 20-25%, if not a few more, that surgery is really not helping. And the question is, can you figure this out? If you knew this ahead of time, who was cured by non-surgical treatment and who was just incurable? That would be very helpful. And I think this is where the most exciting research is coming, because this is going to happen in our lifetime. Perhaps with cell-free DNA, probably not with circulating tumor cells, which was some of my research, unfortunately. But I think using AI to look at a lot of either radiomics or micrographs. I do think there's enormous potential to understand what's going on with our cancers and our treatment, so that we can much more accurately assess things. And so just to close, again, coming back to the horrors of what is an esophagectomy, I just think it's a different era. I think esophagectomies can be done safely. I think people can return to their quality of life as an expectation. But I do think this is a Henry Ford quote: whether you think it can be done or you do not, you are probably right. I think that it is not a given that your surgery is going to be done in a way that's going to leave you highly functional. I think Connecticut is blessed to have a number of talented teams that perform esophageal cancer. We are a 3-star program for the Society of Thoracic Surgeons, but I can tell you we've trained a lot of people in the state, and we're not the only group that does this well. So thank you very much.
Thanks very much, Dr. Boffa, for reinforcing the importance of surgery in this very difficult to treat tumor type. No questions. Okay. Next, we move on to Dr. Du, who's going to talk to us about the advances in radiation oncology.
Okay, hello everyone. I'm just going to share my slides here. And are you seeing my presentation page?
I think you need to swap it, Kevin.
Okay, got it. Sorry. Let's There you go. Okay, so my name is Kevin Du, and I'm one of the radiation oncologists in the Department of Therapeutic Radiology here at Yale, and also medical director of the Trumbull Radiation Oncology Center at the Park Avenue Medical Center. So it's really nice to spend some time here talking with you about radiation treatment for esophageal cancer. And unfortunately, I have no disclosures. The modern radiation therapy, just a word to give you my thoughts, is really, I think, all about trying to use radiation biology, advances in physics and computing technology to really improve our therapeutic index. And there's been a lot of really incredible advances in radiation in the past 20 years. And really, ultimately, the kind of the holy grail for radiation is really how can we improve functional preservation, organ preservation, and how can we improve pathologic complete response and cure more patients with radiation. And so for esophageal cancer, this has actually been looked at really quite a bit in the past 40 years or so. And just to kind of give a basic overview, everyone I think may be familiar with this, but we have two different types of esophageal cancers. And really, in the modern era of esophageal cancer treatment, we approach each one differently in terms of how we think about radiation. So squamous cell cancers and adenocarcinomas being the two histologies. And then we also think, when we think about considerations of radiation, where the location of the cancer is. Is it in the upper cervical esophagus, the middle thoracic, or lower thoracic locations, and how that might affect radiation decision making. And over the years, we've used a lot of different regimens, but as this panel shows, we've really focused a lot in the United States and Europe in terms of looking at combination of chemotherapy, radiation, and surgery. And since the 1980s, there have been many clinical trials looking at this, and this is all kind of put together in some nice meta-analyses a few years ago, showing really, kind of in this, as we look down the unity line here, that many of these trials with chemoradiation before surgery suggest a benefit, but not necessarily a statistically significant benefit. But when you combine all of them together, there is something that suggests favoring chemoradiation for esophageal cancers. And very similarly for chemotherapy without radiation, also crossing unity, but then when you put them all together, potentially suggesting, although just touching unity, favoring chemotherapy. And so despite, I would say, maybe about 20 years of clinical trial work, the question still remained, really, what is anything better than surgery alone? And this is where the cross trial really changed the paradigm when it was published, and this is looking at carbotaxol chemotherapy with radiation prior to surgery compared to surgery alone, and there was an overall survival benefit using neoadjuvant chemoradiation compared to surgery alone. When you break out squamous cell cancers and adenocarcinomas, really, it became very clear that the survival benefit for the cross trial was really driven by the squamous cell cancer subset and not as much by the adenocarcinoma esophageal cancers. And really interestingly, carbotaxol did not seem to affect distant recurrence rates. That is, that even though this combination of chemotherapy radiation was better at reducing local regional recurrence, that it really didn't seem to decrease the rate of distant metastatic disease. So ultimately, the conclusion from the cross trial, my takeaway is that it's a really good regimen, probably for squamous cell cancers, but we probably can do better for adenocarcinomas. There's been a lot of trials since then reported about effective chemotherapy for adenocarcinomas, and looking at more aggressive chemotherapies, does seem that chemotherapy may be equivalent or better than chemoradiation in the setting of surgical resections for adenocarcinomas. And I'm just going to focus on one of those trials, the ESOPEC trial, which made a big splash this year, very high impact, high profile publication. And this was run looking at randomizing perioperative FLOT chemotherapy compared to the cross regimen of carbotaxol and radiation for adenocarcinomas. And it showed that the survival was improved with perioperative chemotherapy FLOT compared to the cross regimen, with really impressive 5-year overall survival rates. And even in adenocarcinomas, with aggressive chemotherapy, FLOT regimen, an improved pathologic complete response rate compared to the cross regimen. And so the ESOPEC trial really showed us, I think, that FLOT chemotherapy is really the appropriate regimen for esophageal adenocarcinomas, and probably more effective than carbotaxol. The question, though, is really this idea of, with more effective chemotherapy, can radiation still add to the benefit of neoadjuvant therapy before surgery when you're using FLOT chemotherapy instead of carbotaxol chemotherapy? And this is a little bit of an older trial, but I like this trial because this trial kind of compared in a roundabout way FOLFOX chemotherapy to carbotaxol, both with radiation treatment. And this was a adaptive trial, so patients were randomized to either FOLFOX or carbotaxol, and then if they responded to one or the other chemotherapy, they then continued on that chemotherapy with radiation. If they were resistant to that chemotherapy, they actually switched over to the other type of chemotherapy together with radiation. And the 5-year overall survival here was about 53%. This was a phase 2 trial, randomized trial, so a smaller trial than our phase 3 trial, but still 5-year overall survival of 53%, which is about similar to the winning arm of ESOPEC. And then also the PCR rate for the folks who responded to FOLFOX chemotherapy was significantly higher at 26%. So, I think that, again, this is kind of comparing two trials, which you're not really supposed to do. But, it kind of gives you a suggestion that maybe FOLFOX-based or 5-FU-based, multi-agent chemotherapy is the way to go with a favorable 5-year overall survival, and that the PathCR rate may be improved still, even in the setting of 5-FU-based chemotherapy, with a more favorable PathCR rate with the addition of radiation. And where this is important is really this idea that Dr. Boffa just really went through in a lot of detail, which is that there's this kind of attractive concept of saying, okay, for folks who have a complete pathologic or a complete clinical response to chemoradiation, can we avoid surgery? And so the Sano trial is one example of that trial. There's others. Interestingly enough, they did look at the global quality of life in the Sano trial, which did improve in the short term, but seemed to level out in the long term. And so that was kind of an interesting finding where, despite patients really probably preferring to avoid surgery, that their quality of life may actually improve given enough time after surgery. And, speaking of quality of life, this has been looked at from the Netherlands. And, I think the idea here is that with chemoradiation across the board, maybe about 20 to 30% pathologic complete response rates across most studies, that again, the holy grail is really to try to figure out is there any way that we can really accurately assess pathologic complete response rates? Is there any way that we can increase the number of patients that achieve this pathologic complete response rate? But this is a nice demonstration that patients prefer organ preservation. And actually they considered organ preservation as the second most important factor after overall survival, and even would accept a trade-off in survival for a significant probability of organ preservation. And so, again, this is something where there's a real need here to improve our results with chemoradiation, and try to make this a more realistic, feasible option for patients. In summary, just the Yale approach to chemoradiation, based off the cross trial, the squamous cell cancers really had the best outcomes there of any preoperative trial for squamous cells. So squamous cell cancers, we're following at this point the cross regimen. For adenocarcinomas, it's clear that FLOT chemotherapy is probably the best chemotherapy regimen. And we may actually add in radiation on top of that, depending on certain risk factors. So patients who are at high risk, who are high-risk surgical candidates, who are maybe unlikely to ever get to surgery because of comorbidities or age or high risk of metastatic disease. These are probably patients that may be better served with chemoradiation. Bulky cancers, where there may be a risk of positive margins with surgery, and extensive lymphadenopathy, where radiation may help to cover the nodal basins. And then as a final 2 minute, 1 minute, 2 minutes note that at Yale we do have some newer things coming down the line for esophageal cancer. One approach, which again is getting more traction, is this idea of treating limited metastatic disease with curative intent. And this is the SABRE COMET trial, which looked at metastatic cancer patients, a small trial, 1 to 5 metastatic lesions with standard of care palliation versus standard of care with SBRT, showing a survival benefit with the addition of local therapy with high-dose ablative radiation, and a series from MD Anderson for esophageal gastric cancers, looking at a similar concept, patients getting systemic therapy with an excellent response, and then consolidation surgery or radiation. And kind of intriguingly, even up to 10 years, about a 20% survival in this highly selected single institution retrospective study. But certainly suggestive that maybe in some patients there can be long-term survival with consolidative radiation. And so at Yale, we have this trial open at this point, which is open through the ECOG group, looking at this concept of consolidative radiation in patients with oligometastatic HER2-negative esophageal or gastric cancer, patients with less than 5 metastatic lesions, and at least stable disease with first-line systemic therapy, and then continuing on to radiation treatment to all of the metastatic sites. And this is an international trial and open now for enrollment. And then finally, just because you can't have a radiation talk without something with new technology, just a note that Yale is going to be opening Connecticut's first proton center, and this should be opening up toward the end of next year in Wallingford, Connecticut. And protons are really attractive and cutting edge radiation technology. And the advantage of protons is that where X-rays go through your body, and no matter how carefully we aim X-rays at the esophagus, there's always this low dose spread of radiation to the lungs and heart. That protons stop. And so you can see in this example of a proton plant delivering dose to the primary tumor, but really sparing a lot more lung from this low dose, and very importantly, sparing a lot more heart. And we know that survival is actually improved the less heart dose we deliver, and that's a big risk with esophageal cancer. So this is something we're looking forward to, and again will be a big benefit, for our patients here in Connecticut. So thank you. I apologize for going over, and I'll turn it back to Dr. Sundar.
Thanks. Thanks, Kevin. That was really fantastic. And looking forward to having a multidisciplinary discussion on some of the cases after this. I'm going to give the last planned talk. Right. And so for the last part, I'm going to cover updates over the last year in systemic therapies, mainly covering the three main components of HER2 targeted therapies, as Dr. Gibson talked about, Claudin 18.2, as well as some immunotherapy updates as well. Um, and this has been one of the most exciting aspects of gastroesophageal cancers, is that in terms of just putative therapeutic targets, we can see that this entire space has really exploded over the past few years. We have multiple different drugs that are coming into the space, and by improving systemic control as well as response rates to primary tumors, the idea is, in combination, as you can see, with radiation as well as surgery, the goal is to try and be able to cure a much larger number of patients who are suffering from gastroesophageal cancer than what we could in the past. So in the HER2 space, we know that the data from Keynote 811, which looked at patients with advanced unresectable gastroesophageal cancers that were HER2 positive, newly diagnosed, and upfront, they were randomized to receive either chemotherapy in combination with trastuzumab, which has been the TOGA regimen, which we have been giving patients for the past 10 plus years, to also then receive pembrolizumab. And this trial had early results that read out a couple of years ago. And we know that there was a progression-free survival benefit for the addition of pembrolizumab to the TOGA regimen with chemotherapy and trastuzumab. And this has been now the standard of care for patients over the past couple of years, where if you're HER2 positive, the addition of pembrolizumab has demonstrated survival benefit. Last year, we actually saw the overall survival results that was presented by Dr. Janjigian and also published in the New England Journal of Medicine. And there continues to be a clear separation of the curves and a survival benefit for the addition of pembrolizumab. This is one of the longest overall survivals we've seen at 20 months for patients who receive pembrolizumab, compared to 16.8 months for those that received placebo, with a very nice hazard ratio of 0.80. And however, one of the things to note about this trial is the fact that there was clearly a lack of benefit of the addition of pembrolizumab for those that had a PDL1 CPS score of less than 1. And in this group of patients, actually, the survival was poorer for the patients that received the pembrolizumab considered compared to standard of care. And that led the FDA to actually update the indication for the role of pembrolizumab and restrict it only to patients that are tumors that had both a co-expression of HER2 as well as PDL1. And so now, in terms of the HER2 positive gastroesophageal cancers, gastroesophageal adenocarcinomas, for frontline treatment, the recommendation is, in combination with the platinum and fluoropyrimidine doublet, is to look at the PDL1 score, and the PDL1 CPS is less than 1, then the recommendation is only for the addition of trastuzumab. But if the PDL1 CPS is 1 or greater, then the recommendation is to add trastuzumab with a PD-1 blockade with pembrolizumab. And that's kind of what we now follow as a standard of care for HER2 positive gastroesophageal cancers. Switching gears a little bit, we know that trastuzumab deruxtecan, which is an antibody drug conjugate before to HER2, demonstrated a survival benefit compared to physician's choice of chemotherapy in the DESTINY-Gastric-01 study. And this actually led to the approval of trastuzumab deruxtecan about 4 years ago now for uh, patients that had progressed on frontline treatment with trastuzumab and then uh, were treated with trastuzumab deruxtecan, which is the antibody drug conjugate. Um, the initial data that was presented in DESTINY-Gastric-01 was purely generated from an Asian study, and this is why we had DESTINY-Gastric-04 study that was a randomized phase 3 trial specifically in the second line setting for patients that have progressed on frontline treatment with trastuzumab-based treatments. And importantly, in this study, all patients had a rebiopsy of the tumors and confirmed HER2 positivity before they were randomized. And they were randomized to receive either trastuzumab deruxtecan or paclitaxel and ramucirumab. And this actually had a press release that announced that this study met its primary endpoint for overall survival, suggesting that trastuzumab deruxtecan did demonstrate an overall survival benefit over paclitaxel and ramucirumab. And this is actually going to be presented as an oral abstract at ASCO in a couple of months. And we're looking forward to hear these data. And this will be practice reaffirming in the United States, where we are very often using trastuzumab deruxtecan in second line. One of the take-home messages from this trial would be the concept of potentially looking to rebiopsy patients and confirm the HER2 positivity status before treating these patients with another HER2 targeted therapy. We also saw very early data from DESTINY-Gastric-03, where they were trying to bring trastuzumab deruxtecan into frontline in combination with 5-FU chemotherapy and pembrolizumab. And these data were actually presented late last year by Dr. Janjigian at ESMO, where there was actually very promising waterfall plots that we saw of the combination of trastuzumab deruxtecan with chemotherapy with 5-FU and pembrolizumab. And you can see almost all the patients responded to treatment with a progression-free survival of about 10 months. One of the concerns about the DESTINY-Gastric-03 was the higher dose of trastuzumab deruxtecan with 6.4 milligrams per kilogram actually had quite a lot of toxicities. And so they actually opened a second cohort with a lower dose of 5.4 milligrams per kilogram of trastuzumab deruxtecan. And this had very similar sort of response rates and survival, but had much, much lower toxicities. And this is what has now translated into the DESTINY-Gastric-05 trial, which is looking at frontline HER2 positive gastric cancer and randomizing patients to receive TDXD, chemotherapy and pembrolizumab, versus the Keynote 811 regimen with chemotherapy, trastuzumab, and pembrolizumab. And this trial is actually opening at Yale very soon. Next, switching gears, Dr. Gibson spoke about Claudin 18.2. This is a normal protein that's expressed, tight junction protein that's seen in normal gastric mucosa, but in cancer cells, the Claudin 18, the tumor cells lose the polarity that leads to an overexpression of Claudin 18.2 on the surface. And zolbetuximab is a monoclonal antibody that binds to Claudin 18.2. A couple of years ago now, we saw two randomized phase 3 trials, the Spotlight and Glow trials. Both trials looked at the combination of chemotherapy. Spotlight looked at FOLFOX, while Glow looked at CAPOX, with or without zolbetuximab in patients that had an overexpression of Claudin 18.2, which Dr. Gibson explained was in more than 75% of the tumor cells. And in both trials, there was an overall survival benefit for the addition of zolbetuximab to chemotherapy, with an overall survival benefit improvement of about 3 months in both trials and a hazards ratio of 0.75. There was also a very clear improvement in progression-free survival that was matched on both trials. And this led to the approval of zolbetuximab in the United States. The FDA approved it in October last year. And so most patients that have an expression of Claudin 18.2 can be offered zolbetuximab in combination with chemotherapy. Interestingly, in both trials, there was no improvement in objective response rates to the addition of zolbetuximab. So although there was a survival improvement, there was no objective response rates improvement as you can see in Spotlight, it was 60.7 in the zolbetuximab arm and 62% in the placebo arm. One of the problems with zolbetuximab is that because the claudin 18.2 is expressed in the normal gastric mucosa, is that there is quite a lot of nausea and vomiting that these patients face, and the nausea and vomiting is very often maximum in the first couple of cycles of treatment with zolbetuximab. And for the medical oncologist listening to this talk, one would say, hey, we know how to deal with high-dose chemotherapy and nausea and vomiting, and this is not something that we need to be taught again. But the truth is that the nausea and vomiting for zolbetuximab is so unique that they actually had to have a consensus guidelines for the management of the nausea and vomiting with zolbetuximab. This was a consensus guideline just published a couple of months ago, and the recommendation is actually for using a highly emetogenic regimen with an NK1 inhibitor, a 5-HT3 inhibitor, dexamethasone, as well as olanzapine, with other recommendations of triplet anti-nausea vomiting regimens as well. But at Yale, we have actually adopted the 4-drug regimen for the treatment of patients receiving zolbetuximab, and the nausea and vomiting has definitely been a lot more manageable with this regimen. Again, a couple of months ago, we also saw the results for joint analysis of both the Spotlight and Glow, again reinforcing this idea that the addition of zolbetuximab to chemotherapy was beneficial, with a very nice hazards ratio of 0.77 for overall survival. And this was published in the New England Journal of Medicine a couple of months ago. One of the things that are unique with gastroesophageal cancers is the fact that a lot of the biomarkers that we use are not oncogene drivers and therefore are not uniquely present in each tumor. And there is a lot of overlap in the co-expression of these biomarkers in tumors. This means that there could be patients that have, or tumors that have expression of both PD-L1 and claudin and HER2. And there's because a lot of the targeted therapies are combined with chemotherapy in the front line, there's a lot of confusion on whether patients who have co-expression of both claudin and PD-L1, for example, should receive either immunotherapy or claudin-targeted therapies in frontline. And to actually answer this question, the Lucerna trial is looking at both HER2 positive and PD-L1 positive metastatic gastroesophageal cancers and randomizing these patients to receive chemotherapy and pembrolizumab with or without zolbetuximab. And this is another trial that's going to be opening up at Yale soon for patients that have both expression of HER2 and, not HER2, sorry, of PD-L1 and claudin. This is an error, sorry. And of course, all of us are familiar with the idea of immunotherapy in combination with chemotherapy for frontline treatment of metastatic gastroesophageal cancers. We have multiple different clinical trials with pembrolizumab, nivolumab, tislelizumab, all FDA approved for frontline treatment in combination with chemotherapy. There's a lot of controversy around the PD-L1 cutoff, and as Dr. Gibson mentioned, we're not going to go into that rabbit hole today, but the idea is that the general principle is that for PD-L1 expressing tumors, that the addition of immunotherapy to chemotherapy in frontline is considered standard of care. One of the questions is there a role for the continuation of immunotherapy into second line? And here we have the Paramune study, which is looking at adding nivolumab to a second line regimen of paclitaxel and ramucirumab for tumors that have a PD-L1 CPS score of 1 or greater. And this study is also going to be opening at Yale soon. And lastly, moving into the earlier phase resectable gastroesophageal cancer space, we have had the Checkmate 577 study that looked at patients that had undergone chemoradiation and surgery and then for those who had not achieved a pathological complete response, were randomized to either receive nivolumab or placebo. And this study had a disease-free survival benefit. And this has been something that we've been offering our patients. But in a couple of months, we are going to see the overall survival data that are going to be presented at ASCO. And we're looking forward to see whether the overall survival will be positive for this important trial. We also saw data from Keynote 585 that looked at the addition of pembrolizumab to chemotherapy in the perioperative setting, followed by surgery. And this was actually a negative trial where, although there was an event-free survival benefit, this did not achieve statistical significance, and the overall survival benefit was not positive for the addition of pembrolizumab to chemotherapy. However, we also saw data from the Matterhorn study that was a more cleanly designed single endpoint study and with a more consistent chemotherapy backbone with FLOT. And in this study, patients with FLOT were randomized to either receive durvalumab or placebo and then underwent surgery and then either continue with durvalumab and FLOT. And this study, we saw earlier data looking at an improvement in pathological complete response of 19% versus 7%. But at ASCO this year, we are going to see as a plenary session the event-free survival of Matterhorn. And the press release announced that this had achieved its primary endpoint and is a positive study. So this is definitely going to be practice changing, and very likely patients are going to be offered FLOT in combination with durvalumab for resectable gastroesophageal adenocarcinomas. And we are going to have multiple, on the background of that, we are going to have multiple perioperative chemotherapy plus novel therapeutic trials that are opening up at Yale in the next few months. At the end of the day, from a systemic therapy perspective, I think Dr. Gibson will also agree that we should be testing all our biomarkers upfront for HER2, PD-L1, Claudin, as well as mismatch repair deficiency. We know that the addition of pembrolizumab to chemotherapy in HER2 positive tumors are beneficial except in PD-L1 negative tumors. The addition of zolbetuximab is important for patients that are Claudin 18.2 positive, but the management of toxicities will be key. Durvalumab in combination with FLOT is likely to be practice changing in the next few months. And we have multiple trial options for patients with gastroesophageal cancers across the entire network. And with that, I'm going to end my talk. We do have a few more minutes for question and answers. I encourage folks to drop in questions into the either into the chat or into the Q&A box. In the meanwhile, we have one of our attendees who's actually an esophageal cancer survivor who's gone through the entire journey of chemoradiation as well as surgery, and perhaps we could give Ms. Deepika a chance to talk. Emily, do you think we could see if we could get Deepika speaking, right? Or is she already a panelist with us? Okay, I think Deepika has speaking. Deepika, can you hear us?
Yeah, I can hear you, but am I audible?
Hi, thanks for joining the call and for dialing in. I'd like to share with us a little bit of.
Yeah, am I audible?
Yeah, it's a little bit faint, but maybe you could
I
speak
am
into the mic.
sorry. Yeah, I am sorry for that, for the voice thing, because one more. Hello, am I audible now?
Yeah, please go ahead. It'll be great to hear your journey through this entire
Okay.
process of
I'm sorry. I'm sorry about my voice. So, hello everyone. I'm Deepika Karki. I'm currently a research fellow at Mayo Clinic, Jacksonville, Florida. And as of today, I am 4 years cancer free. I was diagnosed with esophageal cancer when I was 25 years old, which is 4 years ago. And I was diagnosed in the initial stages. It was a squamous cancer, and it was located 38 centimeters from the incisors. It was 15 centimeters long, and it was 2 millimeters thickness. So I had multiple rounds of chemotherapy, radiotherapy, followed by resection of my esophagus. And post-resection, one of the complications that I'm facing is the paralysis of my right vocal cord. Hence, my voice is very hoarse, and I'm sorry for that. But yeah, it was a great talk, and it's really nice to see all the developments that has been happening in this field. I'm from Nepal originally, so all my treatment was done there, and it does not have as many resources as that was talked in this amazing webinar today. But yeah, just wanted to share it with all of you.
Thanks, Deepika. It's really great to have a success story in this very difficult to treat tumor type, and it's great to see you talk so proudly about your illness and share so bravely about the journey that you've gone through.
Yeah, so a few points that I wanted to talk about after listening to all the wonderful speakers was that we didn't talk a lot about radiation pneumonitis, and that's something that I live with. And and also currently I'm working on this project that is kind of looking at the cognitive function in patients who are diagnosed with cancer, in their adolescent period at a very young age. So I actually did a case report on myself that I'm more than happy to share with the team. And I feel like if we could have more trials targeting on like young patient cohort group, because we mainly talk about therapies for elderly or young pediatric patients, but we don't have a lot of trials that kind of look at a major chunk of that particular patient population. And we talked about quality of life too, so my voice is something that I kind of have to explain on an everyday basis. So that's that. And I had dumping syndrome, which was very bad. And even now I sometimes have postural hypertension and hypoglycemia. So those are some of the quality of life barriers for me. And yeah, just something that I wanted to share about with the team, with the prospects of maybe like more amazing projects that might just come up in the future.
Thanks, Deepika. I think you bring up some very, very good points, and maybe we could use this as the starting point for some of the discussions that we wanted to have. And I think both Dr. Boffa and Dr. Du spoke about this point that we need to correctly select the folks that may benefit from radiation and also be spared from radiation, and similarly benefit from surgery and be spared from surgery. And this brings up this point that all the patients that are treated at Yale are discussed in a multidisciplinary tumor board. Very often, the four of us are on those tumor boards discussing who would be the right patients to get the right sort of treatments. And we are reaching a point where we are getting to a more personalized sort of treatment using biomarkers and other sort of strategies to decide on which patients should be benefiting from which aspects of the various therapies that we have available. But maybe it'll be nice to hear from Dr. Du and Dr. Boffa a little bit on the thoughts that we go through when we decide on these cases, on whether we should be offering radiation as well as offering surgery.
Sure. Deepika, thank you for sharing your cancer journey. And I think that it's important that overall survival is not everything, and that we really have to look at quality of life. And I think that the one of the things that I do think we do really well here is when things don't go the way that we would love them to go, to have ways to mitigate complications of treatment. And so whether it's a recurrent nerve issue and medializing cords, or having like a world-class ENT team, or really a great pulmonary team. But I think your points are really well taken. And I think I never ever talk anybody into an esophagectomy, because it really is a trade-off. It's an investment. And I'm sure you could attest, it's a tremendous recovery. And that trade-off has to be meaningful. The potential gains in survival have to be meaningful. And this is I've had several patients in their late 20s. But a lot of our patients are in their 80s and are facing this. So you have both ends of the spectrum, and trying to really be transparent about what is the potential to gain from each modality of treatment, including systemic treatment and radiation and surgery. And what is the likelihood of experiencing an event that degrades quality of life?
Yeah, I'll follow Dr. Boffa, as radiation generally follows surgery, but this is something where Miss Karki, this is really an amazing story, and thank you so much for sharing. Congratulations on your 4th anniversary of being cancer free. It's really amazing. I share a lot of what you say, where when I walk in and talk to patients in the room, I do try to really take into account and try to figure out what the right treatment is for them. Radiation is a difficult treatment. It's a lengthy treatment. There's a lot of side effects that are associated with radiation to the esophagus. And so it really is not the right treatment for everybody. However, overall, we try to assemble a treatment package that combines the best chances of success together with trying to figure out what's best for the patient's quality of life going forward. We need better treatments, that's for sure. So that's where the research that Dr. Raghav Sundar is talking about are so important. Novel therapies. Proton therapy, I'm really sorry to hear that your lungs were impacted by the treatment. I think that's a big advantage of newer radiation therapies like proton therapy, which patients don't have, may have only limited access to. Protons are not everywhere. But has been demonstrated really to reduce the dose to the lungs and the heart, as I was showing earlier. But that being said, I'm so glad that you're doing well after treatment, and and at a great place down in Florida, pursuing things that are important to you. Thank you for sharing.
Thanks, Dr. Du. I have a question to Dr. Gibson as well as to Deepika, because if Deepika, you shared your case report with us, and you actually achieved a pathological complete response. So my question is to Deepika will be, at that point where you had to make that judgment call, you would have been clinical complete response. And so the decision to still go ahead with surgery to be really sure that you have no disease left behind. I want to hear your thoughts on the journey. And separately to Dr. Gibson is, how much of discordance do you see between CCR and PCR? Because that's always going to be this judgment call when we try to head down this non-operative route. And do we always need to get PCR for us to be confident that we've gotten rid of everything, or is CCR good enough? I mean, Dr. Boffa spoke a little bit about it, but I'd like to hear your thoughts on this. Maybe we'll hear Dr. Gibson's thoughts first and then listen to what Deepika had to think about.
Sure. Yeah, I also want to say thank you to Deepika for sharing her story. I think it's incredible to hear these real life experiences, and it really paints a picture of what people go through. When I signed that report that there's cancer found, I think for it's actually a really good question, clinical complete clinical response versus complete pathological response. I actually don't have a study off the top of my head that sort of looked into that. We are not following that as a metric at Yale that I know of, unless Dr. Boffa has something that his group is doing. So I actually think it would be interesting to, look into that a little bit more. I will say that complete pathological response is not a simple concept. I think I would encourage anybody who reads papers that evaluate that to understand how exactly the esophagus resections were examined. And when we examine post-treatment esophagectomy specimen, we have a protocol where we examine the entire tumor bed histologically, and that can sometimes be really difficult to tell. So we end up submitting, the entire area where the tumor might have been, if we can't identify a good tumor bed. So we're, doing a complete assessment of that, of the tumor site. And I would say there's not, depending on where you practice, that might be different. There might be different approaches of how pathology is assessed. And so I think before you sort of look at a paper and look at the pathologic complete response data, understanding what the protocol was to examine the esophagus is an extremely important exercise. Because if they did not examine the entire tumor bed, they might have missed that residual bit of cancer that was in there. And we see that. We will submit an entire tumor bed, let's say a 3 centimeter scar at, above the GE junction. We'll submit that, examine that in, 15, 20 blocks, and there'll be cancer on 1 or 2 of them and not the rest. And so you really could miss it if you're not doing a complete pathological response. So that's my one cautionary tale about that and data about that. But yeah, I don't know the data offhand comparing the clinical versus pathological response. So that's something I would need to look into a little bit more. And I don't know if anybody else has insight into that. I'm sure Dan has some insight, or Kevin, I see you unmuted as well.
I think you can flip a coin with a clinical complete response, and that'll be about as good as anything. To Dan's point, I think we absolutely need better ways of assessing, such as circulating, blood tests, tumor markers, or even AI approaches. That's really the most important question with chemoradiation and these days, I think, and something which could really revolutionize the field, I think, and really improve our patient care.
Yeah, I agree with that. There's about a 50% false negative rate to the clinical evaluation. That is really what pre-Sano showed. That's what we'd found when I was in Cleveland, and it's a pretty consistent thing. But we know that not every pathologic complete responder is cured. So Joanna, that's a really interesting point that I didn't really think about, is how the processing does, nobody likes to look for things they don't want to find. And, it is interesting to understand the different processing. That would be an interesting study, is to sort of look at complete pathologic responders, have different centers look at the same things to see if there's concordance in that. But
I think just looking at the protocols and sort of understanding how people are assessing that, that point, I think would be interesting. Yep.
And just on that note, you can see that a new study is forming at the end of this webinar with this group. But I also want to highlight the fact that we're very, very dependent on the pathologist for our decision making. And so we're grateful to having a very strong and collaborative pathology team at Yale that helps us make a lot of these decisions downstream. Deepika, are you unmuted? Can you share your thoughts on going for surgery despite
Hello?
CCR? Yeah,
Yes.
please.
Yeah, I'm so sorry. I always do the voice test before I speak. So yeah, as for me, it was like after I finished my treatment with chemo and radio, my surgeon, he performed an endoscopy on me. And on that, he found a polyp. And I was actually like clinically well ever since my first dose, like my first session of chemotherapy. So there was like never a question of not being a clinical responder. But when he found that polyp on a follow-up endoscopy, and considering my age, like he kind of counseled me and my family for esophageectomy. And yeah, that's I think how I like gave into it. And that being said, I think the initial months were definitely very hard because I couldn't eat, and I had dumping syndrome and it was very hard. But right now, like years down the line, I'm able to have a full meal and I'm much better. And just the fact that my parents and my family, we're all kind of, happy that the main source of where the lesion was is gone from my body. So I think that's one sense of like relief that me and my family have. And my follow-up PET scans have also come out all clean. So I guess that also kind of helped me and my family make that judgment about to go or not with esophageectomy. So yeah, I think that really helped.
Thanks, Deepika. It was really nice to hear your journey and glad to hear that you recovered. Um, I think part of the decision to operate would have also been that you were diagnosed at a very young age, and I think most people, to Dr. Gibson's point, most people wouldn't want to risk leaving any tumor behind. So that's great. I have a couple of questions in the chat. I think both I'll try and address. So one question is the question of looking at the addition of trastuzumab with FLOT for HER2 positive adenocarcinoma. So we actually have the innovation trial that looked at this um, with both trastuzumab as well as pertuzumab, not with FLOT, but with older chemotherapy regimens, which was negative. And so that study um, didn't show any benefit in the addition of HER2 in the perioperative setting. And so we need to be careful about extrapolating data from the metastatic setting and moving it into the perioperative setting without having clinical trials to support some of these data. The other question was any chance of improving on cross. Um, that part, actually, the truth is, at least at Yale, we all firmly believe that cross was not the best regimen from a chemoradiation perspective for adenocarcinoma specifically. For squamous cell cancers is a different story, and we think carbotaxol in combination with radiation is beneficial. Um, Importantly, the cross regimen has a much lower dose of radiation with just 41.4 grays, which is very different from a more definitive dose of radiation, which is 50.4 grays. And the carbotaxol is at very low doses of chemotherapy with just 50 milligrams per kilogram of paclitaxel weekly for 5 cycles and 1.5 AUC of carboplatin 5 for 5 cycles, which typically is not good enough for systemic control. And so most of the regimens that we use would have much higher doses of chemotherapy with chemoras, either using FOLFOX like the CALGB 80803 regimen, or just having FLOT as a chemotherapy with 5-FU, oxaliplatin, as well as docetaxel to improve the perioperative outcomes. And this is an area of a lot of controversy and a lot of research uh, that people are people are working on. We are at the top of the hour, so I'm going to take this opportunity to thank everyone for joining us today. Take this opportunity to have my fantastic panelists joining me and giving great talks. And thank you very much for joining us today, and have a great evening.